Good morning, ladies and gentlemen, and I would like to thank for this kind invitation to this 11th Nestle Forum on Nutrition, and I would definitely like to thank this kind invitation and Fonsalud as well. I would like to issue some reflections, some thoughts about the problem that we're concerned with today, namely So, I would like to give you my thoughts about the current situation that we're living in Mexico regarding diabetes. And I would like to leave you with this idea that I'm sure you already have, that diabetes may be the key, the most important public health problem that Mexico is facing. And putting aside the violence problems that Mexico is suffering, I believe that diabetes, together with violence, could be one of the key problems in Mexico. So, diabetes and its key risk factors interfere in an important manner in the national productivity. And as we will see, diabetes is also the cause for poverty, because the people that face the greatest economic difficulties, the low-income people, are severely affected by this disease. The number of people with diabetes was doubled from the year 2000 to 2012. This is telling us that we have a growing tendency, an epidemics. Nowadays, we know through data coming from the National Survey on Nutrition and Health that 6.2 million Mexicans already have a medical diagnosis of diabetes, and they are already under treatment in the healthcare sector, or maybe another 4.5 or 5 million Mexicans have not yet been diagnosed, but they are also affected by this disease. 83,000 people died in 2010 at an earlier age, at 66.7 years age, and when the life expectancy is 76 years old in Mexico. We have cost-effective interventions in Mexico. I believe that this is one of the diseases about which we truly know what to do, both in the preventive area and in the primary prevention care and the hospitalization care. However, the epidemics in Mexico continues with severe problems of care. 75%, we will see that 75% of the people that have already been diagnosed with diabetes and that we have interviewed and we have taken a blood sample, they do not have a proper control of their disease. And this is reflected in the fact that diabetes is now the first cause of cardiovascular diseases, of blindness, of terminal kidney failure, and amputations. The cost for the healthcare sector, as estimated by the National Institute of Public Health, are of around $7,000 million, and almost 75% of this cost goes to late complications of diabetes, which is what we could forecast. Of course, Mexico has already set into operation a number of specific action programs. However, our efforts are lost due to three problems. Number one, the fragmentation of the healthcare sector that we have, and this is very important because it interferes with the quality of care. And it is not just the fragmentation that we have in the healthcare providers, but also the segmentation that we have at levels that have no reference or counter-reference patterns that are very clear. And also we will see that a very important barrier that diabetic patients in Mexico face is the suboptimal quality of the healthcare services. And also we will see that it is a weak empowerment of people that come with diabetes to take care of their own disease, to participate in the treatment of the disease. I will also share with you the results of the National Survey on Health. Also, the data that I mentioned before on the quality as perceived in the first level of care, and I will also add some information regarding the impact of this lack of quality of this or this suboptimal quality. What is the impact on the second level? How do we see this in terms of costs and hospital stays and in terms of preventable mortality that are also important? Finally, some conclusions. Now, whether or not diabetes is an epidemic in Mexico, it is obvious that it is. Mexico is one of the countries with a very high prevalence. Now, on account of the efforts through this Institute of Genomic Medicine, etc., we know that we Mexicans have an important genetic load that predisposes. We have an important burden. Here in this chart, taking into account age differences, we see that Mexico has a prevalence of 15.9% if we adjust it to the global prevalence, and it is considerably higher than that of all the other countries in the OECD. Now, as I mentioned before, we have a good system of health survey, which allows us to see the behavior of diabetes. In 1994, when it was the first time that we measured this prevalence of diabetes, we had a prevalence of 4%. By the year 2000, prevalence was increased to 4.6%. But between 2000 and 2012, this prevalence was doubled. In the diagnosis, that is, when we did the survey, we asked the people that participated whether any physician had already given a diagnosis of diabetes. And 9.2% of the population told us that this was the case. Now, is this question adequate? Yes, because later on we studied this through a blood sample and then we corroborated the diagnosis that these data are true. As I said before, there is a percentage that is not properly estimated. We estimated it back in 2006. The people that participated in the survey are also taken a fasting glucose sample. Therefore, the prevalence detects another 7%. We still don't know the results for the survey for 2012, but we will have them shortly. Now, the epidemics has been increasing in all of the age groups, but this is an important effect also at younger ages as such. And that implies that the diagnosis is being made at earlier ages. And this, of course, further increases the burden of the disease. Now, in terms of coverage, we know that 11% of people that are covered by the Mexican Social Security Institute have a pre-diabetic diagnosis, a bit less in the popular insurance. Those that mentioned that have no social coverage, 7.6%, and those that have no coverage at all, 6.8%. Now, this further reflects the differences in ages and the different burdens that the healthcare services will have to endure. Now, here we can see the institution that reports the healthcare protection, the ones that provides the coverage for these patients. We see that 15% of diabetic patients report to have no coverage at all. 41% report that they are covered by the Mexican Social Security Institute, and 12% a different social security institution, and 30% by the popular insurance. However, when we see about the care that they receive, we see that a significant number of these patients that have institutional coverage end up in private services, 21%. This is important because we may lose the continuity in the treatment. And also, if we take a look at the income level, we do not see a tendency. We rather see that the level of income does not have a really important role to play. And we see also that in the quintiles 1 and 2, we see the greatest distribution, 20% mostly of patients with diabetes. This means that these homes that are under an economic pressure will be facing a greater pressure because of the burden posed by diabetes. And this will further increase our possibilities of being in overt poverty. Now, moving on to what people that live with diabetes have told us during the last year, we see a pattern with a wide range for improvement. And if we see here, if these people were prescribed statins, people over 40 that have this lipidemia, that should be 100%. We are only at 16% in 2006, and we went up to 21% in 2011. One indicator that is complied is when people are using insulin, the use of daily insulin that reaches 96 or 93%. However, the factors that have to do a lot with the change in behavior, that should be, for example, indication of a nutrition plan and exercise or reduction of consumption or uptake of salt with high blood pressure, diet for people with high levels of cholesterol, we have suboptimal results because we are at around 3%. If we see the annual checking of the fundus of the eye, we went from 12.3% to 8.6%. And if we talk about the glycemic control, we see, for example, that HbA1c, we have not been able to include it in the medical standards, although the Mexican official standard indicates that it should be used. We used to be at 3.7%, and now we are at 7.7% in 2012. This means what the patient tell us that they actually took this test. And if we see glucose, glycemia, we are at 35%. So this means that at the first level of care, we actually have lots of room for improvement. Now, if we compare ourselves in terms of the HbA1c as a marker, in Mexico, in 2012, 25.4% of the people that we studied in a national probabilistic sample had a control that could be considered as the proper one. However, if we compare ourselves with Canada or the United States, of course they have a better level in the populational studies that they did in 2005 and 2010. That is to say, we are below the international comparison. If we widen the range of hemoglobin and we compare it to the U.S. in 2010, we see that patients that are at a higher risk of having complications on account of their level of their HbA1c or higher than 10 in the U.S., it is around 7%, but we are at around 36%. So this once again tells us about the control problems that we have. Now, if we see the percentage of patients that are already starting to report complications, we see that there is a very important relationship with the duration of the disease. And we see with great concern that there are patients that are diagnosed at a late stage because they have been diagnosed less than 1 year before they have already had a hospitalization because of diabetic coma, or they report having had an amputation. However, we also notice that throughout the course of the disease, the different complications increase. And at the end, the ones that report having diabetes for over 12 years, they report important rates of hospitalization due to diabetic coma, amputation 4.5%, or a dialysis 2.5%. Now, if we try to provide a dimension to this problem in the quality of the level of care in the first level and in the second level, we have done this by using this concept of conditions that are susceptible to the quality of primary care. And here, what the literature states is that the quality of the primary care has a direct impact upon the patterns of demand for hospital services, and there should be some diseases about which patients should not be hospitalized because they should be taken care of at the first level of care. And there is an international consensus that tells us about what are those causes that could be prevented at the first level of care. And they are very well stated here. I'm showing you. The idea is just to make emphasis on the fact that they are well determined in terms of the diagnosis. And then we decided to go and look for those causes in our registries of hospital admissions, and I'm going to show you the data related to what we see about diabetes. This is more or less the dimension of the data. We're talking about 2 million hospital discharges per year, and we have them distributed according to the different healthcare providers. It is difficult to see, but here we have it in a chart form, and we see, for instance, that at the Ministry of Health there were over 2 million hospitalization in 2002. This has increased. This is part of the effect of the popular insurance to improve access. And here we see, percentage-wise, the number of hospital admissions that could be susceptible of being contained. So here we see that we still have a very important problem because 17% or 15% of hospital admissions at the Ministry of Health could be prevented. 21% at the Social Security Institute with a slight increase. At ISSSTE, we see a slight decrease. At IMSS Oportunidades, ISSSTE the same. This gives us an idea of the efficiency of the primary level of care. It is concerning that all of them have the same problem. That is, that we were not able to make a difference among the healthcare providers. Now, if we talk about the causes, here we have 100% of the hospital admissions. In each bar, we have the sector that is represented, the healthcare service or the popular insurance, the Navy, Pemex, the ISSSTE, IMSS Oportunidades, and the Mexican Social Security Institute. Of course, this, to start with, gives us an idea as to the segmentation that we have on a segment basis and how inefficient the sector could be in keeping this level of care. Now, and we can see diabetes, which is here, and it is represented in the upper part. It is accountable for almost 2% of the hospital admissions that could be prevented. At ISSSTE, in accordance with the age distribution that we have, because we have an older population, they account for a larger number. However, this tells us that in the first level of care, we're not really doing anything or things we should do. If we see hospital discharges due to complications related to diabetes, we see the same thing. We have the two large healthcare providers, the Seguro Popular and the Social Security Institute and ISSSTE. And if we chart this on taking age as the basis, we can see the impact of diabetes, a very important impact upon the hospital discharges. Here we see the different sectors, and we can see in red the percentage of hospital admissions. Now, if we see this, if we remove all of the other diagnoses, we can see that diabetes starts putting some pressure upon hospital admissions, and very importantly, from 40 years of age until 75 up to 79 years of age. They are young adults that are being hospitalized, and the pressure is the same, both for men and for women. And now, if we provide an economic dimension to this problem, just For 2012, we had 168,000 hospital discharges related to diabetes, 685,000 hospital stay days. If we estimate the average cost per bed and per day, 2,150 pesos for IMSS and 5,500 pesos for the popular insurance. This amounts to 1,473 millions, and then 3,700 million pesos. If we could reduce these hospitalizations, we could be talking about an annual saving between 300 and 750 million pesos. So it can be done. Now, if we move on to preventable deaths as such, I'm going to put them in a chart by using the metabolic causes, mostly diabetes. Here we can see in this picture we have women, and we can clearly see hospitalization to diabetes. And here are men. And what I told you at the beginning, the part of violence, actually we consider that regarding violence, all the deaths could be preventable. But here, talking about diabetes, once again, we see an increase among males. And if we remove all the other causes, we can clearly see that it is an important rate, 15 for every 1,000, and in males, it is increasing. And this, of course, tells us about a premature mortality, and these are the 80,000 deaths that I mentioned at the beginning of my talk. Now, if we see this on an age group basis, we can also notice that deaths are happening at the younger age groups, 50 to 54, and then 55 to 59, 64 in males, and in women, the same age groups are being affected. Therefore, we have a very important loss of life years, and we have to remember that this is a chronic disease, and this further brings about a huge accumulation of non-healthy years of life or with disability related to this disease. If we see this in terms just for diabetes, we can see the importance. It contributes with up to 30% of preventable deaths among people between 60 and 64 years of age. So we can say that in Mexico we have a wide range for improvement. However, I also believe that the complexity of our system, the scarcity of resources that we have, and the pressing needs imposed by the epidemics of diabetes makes it very difficult for us to set a priority. I could make a commercial. Next Tuesday at the National Academy of Medicine, we will see a work led by Carlos Aguilar in which a prioritization is made to try and identify the areas in which we have to work. So we would have to ponder, where should we direct our efforts? Where will we have the greatest benefits for people's health? Because let's remember that diabetes imposes a very important burden on the patients. They have to follow a rigorous regimen of treatment, and also they have to change their lifestyles, and for that they have to be empowered, and they need support. The access to medical drugs and monitoring equipment is essential, because we have done a lot of support in what regards medical drugs, but the monitoring equipment continues to be an economic barrier for patients. They are saying that we have two priorities, or that they are very important. Number one is to prevent complications, and this equals reinforcing the first level of care in order to prevent complications and to further empower people living with diabetes so that we can have a direct impact upon their treatment. Number two, we have to prevent people from developing diabetes. And here we're talking about primary prevention. And in this regard, I would like to first state that the part regarding complications, we will have to reinforce, and this is very important, we'll have to reinforce personal healthcare services. We'll have to work on the training of our physicians. We will have to work with technologies and on the empowerment of patients. And regarding non-personal healthcare services, we would have to work also with effective communication campaigns by modifying the environment so that people that live with diabetes will have an access to information on diets, the information on access to exercise, and so that patients can go through this transformation. We also have a very important area of opportunity outside the healthcare sector, and this is the one that we tend to forget. I believe that the National Crusade Against Hunger, if I had taken an important should have made contributions to diabetes, because 20% of people, or actually 12% of people living in poverty already have diabetes. And this further contributes to the development of poverty in Mexico, and also the participation of the private sector is needed. Events like this one help us strengthen this support. All of this leads us to have an impact upon social and economic equity, because we are in a globalized world, and this also imposes responsibility. Mexico is a member of the Alliance Against Chronic Diseases. There are better elements for funding, and we also have the commitments that we have accepted at the World Health Organization, and this would lead us to better results. We already have a working paper in Mexico, which is the National Strategy for the Prevention and Control of Overweight and Obesity, which gives us this as our vision for 2008, a reduction in the relative risk of mortality for diabetes, genetic diagnosis, a relative reduction in prevalence of physical inactivity. Also, we have to stop the increase in overweight, obesity, and diabetes, and an increase in the control for diabetic patients. And I believe that this document will provide us with a path to follow, and essentially it helps us set a priority on the actions that we should follow. And this is the end of the presentation. Thank you very much.